Yesterday, the American College of Cardiology and American Heart Association published the 2025 Guideline for the prevention, detection, evaluation, and management of high blood pressure in adults. What do you need to know? The document is packed with valuable information spanning 80 pages, excluding references. So I want to break it down for you and highlight the most important changes you need to know about for your practice. The 2025 High Blood Pressure Guideline updates recommendations from the previous high blood pressure guidelines from 8 years ago in 2017. While the 2017 guideline had made a major change to how blood pressure was categorized, the 2025 guideline does not change the blood pressure categories. They remain the same as in 2017. Less than 120 systolic and less than 80 diastolic is normal blood pressure. 120 to 129 systolic and less than 80 diastolic is elevated blood pressure. 130 to 139 systolic or 80 to 89 diastolic is stage 1 hypertension. 140 or more systolic or 90 or more diastolic is stage 2 hypertension. Also unchanged are these blood pressure categories, which are more clearly and helpfully spelled out in this year's guideline. They differentiate the categories for individuals not taking antihypertensive medication and individuals who are taking antihypertensive medication. Among individuals who are not taking antihypertensive medication, of course, if blood pressure is normal in the office and normal at home, that is sustained normal tension. If blood pressure is high in the office but normal and also high at home, that is sustained hypertension. If blood pressure is normal in the office but high at home, that is masked hypertension. If blood pressure is high in the office and normal at home, that is white coat hypertension. Now, among individuals taking antihypertensive medication, of course, if blood pressure is normal in the office and at home, that is controlled hypertension. If blood pressure is high both in the office and at home, that is uncontrolled hypertension. If blood pressure is normal in the office but high at home, that is masked uncontrolled hypertension. If blood pressure is high in the office but normal at home, that is the white coat effect. The recommendations for accurate blood pressure measurement technique also remain the same. They recommend that the patient should avoid caffeine, exercise, and smoking for at least 30 minutes before measurement. Ensure the patient has emptied their bladder. Use a blood pressure device that has been validated for accuracy at validatebp.org. Use the correct cuff size on a bare arm. The patient's arm should be supported at a heart level. Have the patient relax, sitting in a chair, feet on floor, legs uncrossed, and back supported for more than 5 minutes of rest. Neither the patient nor the clinician should talk during the rest period or during the measurement. The patient should not be using their phone. Blood pressure measurements should be taken in a temperature-controlled room. Take 2 or more blood pressure measurements at least 1 minute apart. Average the readings and provide the patient their blood pressure readings both verbally and in writing. In addition, the labs to order for a new diagnosis of hypertension remain the same. Complete blood count, serum potassium, sodium, and calcium, and serum creatinine with estimation of the glomerular filtration rate based on the new 2021 CKD epicreatinine equation, a lipid profile, fasting blood glucose or hemoglobin A1C, thyroid stimulating hormone, urinalysis, urine albumin to creatinine ratio or urine protein to creatinine ratio, and ECG. Now let's take a deep dive into the new recommendations and the revised recommendations in the 2025 High Blood Pressure Guidelines. I am speaking about this guideline with assumption that you have some awareness of hypertension management and diagnosis and the 2017 High Blood Pressure Guideline. The first new recommendation is in section 3.2.3, secondary forms of hypertension. In 2025, it is a class 1 recommendation in adults with resistant hypertension, screening for primary aldosteronism is recommended regardless of whether hypokalemia is present to increase rates of detection, diagnosis, and specific targeted therapy. Why? Because spontaneous hypokalemia is present only in 20 to 50% of patients with primary aldosteronism, and therefore the decision to perform primary aldosteronism screening should not rely solely on a history of hypokalemia. This was not explicitly present in the 2017 guideline. Next, we have a new recommendation in the section on primary aldosteronism. In adults with an indication for screening for primary aldosteronism, it is recommended to continue most antihypertensive medications other than the MRA prior to initial screening to minimize barriers to or delays in screening. That's a Class 1 recommendation in 2025, with no equivalent in 2017. Why? Because low screening rates may occur due to several barriers to screening, such as older guidance to withdraw antihypertensive medications that may affect renin and aldosterone levels, which has since been disputed by growing evidence in support of screening despite treatment with these medications. Specifically, beta blockers and central alpha agonists can suppress both renin and aldosterone. ACE inhibitors, ARBs, may stimulate renin and suppress aldosterone. Thiazide type and loop diuretics, MRA, and potassium-sparing diuretics can stimulate both renin and aldosterone. Initial screening for primary aldosteronism can typically be interpreted in the context of most medications that affect renin and aldosterone. If screening results are negative or borderline in patients in whom there is a high level of suspicion for primary aldosteronism, and confirmation of the diagnosis will change management, potentially interfering medications may be temporarily substituted with non-interfering medications, such as non-dihydropyridine calcium channel blockers, vasodilators, peripheral alpha blockers, and potentially dihydropyridine calcium channel blockers for at least 2 to 4 weeks prior to repeat testing. There's a new recommendation in the section on lifestyle and psychosocial approaches. In 2017, they had written potassium supplementation, preferably in dietary modification, is recommended for adults with elevated blood pressure or hypertension, unless contraindicated by the presence of CKD or use of drugs that reduce potassium excretion. In 2025, they retain a version of that statement, but they add a new statement for potassium-based salt substitutes. In adults with or without hypertension, potassium-based salt substitutes can be useful to prevent or treat elevated blood pressure and hypertension, particularly for patients in whom salt intake is related mostly to food preparation or flavoring at home, except in the presence of CKD or use of drugs that reduce potassium excretion, where additional monitoring is probably indicated. That's a Class 2A recommendation in 2025. Potassium-based salt substitutes are salt substitutes that contain usually 25 to 30% potassium chloride, 65 to 75% sodium chloride, and 0 to 10% flavoring agents. Products that refer to themselves as salt substitutes that do not contain potassium chloride as a substitute for sodium chloride have unknown effects on blood pressure and cannot be recommended at this time. Why did they add in this statement this year? Because compared with the use of regular table salt, which is all sodium chloride, use of a potassium-enriched salt substitute causes approximately a 5 and 1.5 millimeter of mercury systolic and diastolic blood pressure reduction, with variability depending on the subgroup and the amount of sodium replacement. In the largest trial of potassium-based salt substitutes to date, 20,000 adults in China with either a history of stroke or age of 60 years or greater and uncontrolled blood pressure were enrolled in a cluster randomized trial comparing a salt substitute, which was 75% sodium chloride and 25% potassium chloride, with regular salt. Use of the salt substitute was associated with a systolic blood pressure reduction of 3.3 milliliters of mercury and significant relative reductions in stroke, MACE, and all-cause mortality of 12% to 14%, with no concomitant increase in risk for hyperkalemia. So that's pretty remarkable. The guideline also notes that in the United States, the majority of sodium intake comes from consumption of processed foods or meals prepared in restaurants, so use of a salt substitute may be of greatest benefit in individuals who are consuming most of their sodium at home from salt added during food preparation or at the table. There is also an interesting new recommendation in the Lifestyle and Psychosocial Approaches section about meditation. In adults with or without hypertension, stress reduction through transcendental meditation may be reasonable to prevent or treat elevated blood pressure and hypertension as an adjunct to lifestyle or medication interventions. Class 2B. Also, in adults with or without hypertension, other forms of stress management such as breathing control techniques or yoga may be reasonable to prevent or treat elevated blood pressure and hypertension as an adjunct to lifestyle or medication interventions. Class 2B. Neither of these were explicitly mentioned as a recommendation statement in 2017. Why did they add this in? Because there is consistent moderate to high level evidence from short-term clinical trials that transcendental meditation can have lower blood pressure in patients without and with hypertension, with mean reductions of approximately 5 and 2 millimeters of mercury in systolic and diastolic blood pressure. Medication appears to be somewhat less effective than blood pressure lowering lifestyle interventions such as the DASH eating plan, structured exercise programs, and low sodium or higher potassium intake. Now, in terms of the other stuff like yoga, breathing control techniques, they note that among these other stress-reducing and mindfulness-based interventions, data are less robust and evidence is of lower quality because of the smaller short-term nature of those trials with heterogeneous interventions and results. There is moderate-grade evidence that breathing control interventions can lower systolic and diastolic blood pressure by 5 and 3 millimeters of mercury in people with and without hypertension. There's also low to moderate grade evidence that yoga of diverse types lowers blood pressure. Table 12 in the guideline provides a nice summary of the evidence for lifestyle and stress reduction interventions to lower blood pressure, including weight loss, heart-healthy diet using a DASH eating pattern, reduction of intake of sodium, use of salt substitutes, enhancing intake of potassium, reducing alcohol consumption, exercise, which they differentiate between aerobic exercise, dynamic resistance exercise, and isometric resistance exercise, meditation, and breathing control. There was a prominent Bayesian network meta-analysis that assessed the comparative effectiveness of 22 lifestyle and stress reduction strategies for blood pressure lowering. The DASH eating plan ranked as the most effective intervention for blood pressure lowering, followed in order by aerobic exercise, isometric resistance training, low sodium, high potassium salt interventions, and comprehensive lifestyle interventions. Meditation and breathing control appeared to be the most effective stress reduction technique that had at least moderate quality evidence, but was judged to be less effective than lifestyle interventions. It should be noted that the blood pressure response to any given intervention will vary across subgroups and individuals and is a function of the fidelity and intensity of the intervention, patient adherence, and, in some cases, the starting blood pressure level. Next, we turn to the section on blood pressure treatment threshold and the use of cardiovascular disease risk estimation equations to guide drug treatment of hypertension. In 2017, they wrote, use of blood pressure lowering medications is recommended for secondary prevention of recurrent cardiovascular disease events in patients with clinical CVD and an average blood pressure of at least 130/80 millimeters of mercury, and for primary prevention in adults with an estimated 10-year ASCVD risk of 10% or higher and an average blood pressure of at least 130/80 millimeters of mercury. Now, they say in adults with hypertension and clinical cardiovascular disease, initiation of medications to lower blood pressure is recommended when the average blood pressure is at least 130/80 to reduce the risk of cardiovascular events and total mortality, with a class 1 indication. Why? Because among individuals without clinical cardiovascular disease but at increased cardiovascular disease risk, initiation of antihypertensive therapy at an SBP threshold of 130 or higher reduces cardiovascular disease. There are 3 groups of individuals who were identified at increased cardiovascular disease risk even though they do not yet have clinical cardiovascular disease. 1 is individuals with diabetes, 2 is individuals with chronic kidney disease, and 3 is individuals aged 30 to 79 years without cardiovascular disease, diabetes, or CKD, but who have a 10-year estimated cardiovascular risk of 7.5% or higher using the PREVENT equations. I'll go over this in the next couple slides. In 2017, they had written use of blood pressure lowering medication is recommended for primary prevention of cardiovascular disease in adults with no history of CVD and with an estimated 10-year ASCVD risk of less than 10% and systolic of 140 or more or a diastolic of 90 or more. Again, these ASCVD risks in 2017 were based on the traditional pooled cohort equations, whereas this year we have moved on to PREVENT. They say in adults with hypertension without clinical CVD and with estimated 10-year CVD risk of less than 7.5% based on PREVENT, initiation of medications to lower blood pressure is recommended if average systolic blood pressure remains 130 or higher, or average diastolic blood pressure remains 80 or higher, after a 3 to 6 month trial of lifestyle intervention to prevent target organ damage and mitigate further increases in blood pressure. That's a class 1 recommendation. What's the reasoning behind this? In adults without clinical CVD who are at lower 10-year predicted cardiovascular risk based on PREVENT equation estimated risk of less than 7.5%, there's limited data about the net benefit of initiation of antihypertensive therapy when there's a lower threshold with an average systolic blood pressure of 130 or higher. Therefore, in this population, they encourage lifestyle interventions first to lower blood pressure, as mentioned in the first few slides. However, lifestyle interventions may be not successful at lowering systolic blood pressure, and even when successful initially, it can be difficult to sustain optimal systolic blood pressure levels. Therefore, if the systolic blood pressure is 130 or above after a 3 to 6 month trial of lifestyle interventions, then initiation of antihypertensive therapy is advised as an adjunct to lifestyle interventions. This is supported by the PREVER prevention trial, the hypertension prevention in pre-hypertensive individuals trial, which demonstrated lower rates of progression to stage 2 hypertension, defined as 140 or higher, systolic, 90 or higher diastolic, and end organ damage in the left ventricular mass following a 3-month lifestyle intervention among participants with elevated blood pressure of 120 to 139, systolic 80 to 89, diastolic, who were subsequently randomized to diuretic treatment compared with placebo in adults with age 30 to 70 years. In other words, both the 2017 and 2025 high blood pressure guidelines recommend that adults with stage 1 hypertension with low cardiovascular disease risk should be managed with lifestyle interventions before initiation of medication, except the 2025 guideline now recommends the use of PREVENT to calculate risk. Let's see how this is all put together in Figure 6, use of risk-based thresholds for initiation of blood pressure treatment in adults. First, look at the blood pressure. Does the patient have an average blood pressure of at least 140 or 90 millimeters of mercury? If so, the answer is simple. Initiate antihypertensive medications to lower blood pressure and reduce cardiovascular risk for primary or secondary prevention of cardiovascular disease. That's a class 1 recommendation. If the blood pressure is not yet 140 or higher, then think, does the patient have existing clinical cardiovascular disease such as coronary heart disease, stroke, or heart failure? If so, Then go ahead and initiate antihypertensive medications to lower blood pressure and reduce cardiovascular disease risk if the average systolic blood pressure is 130 or higher, or diastolic is 80 or higher, for secondary prevention of cardiovascular disease. That's a class 1 recommendation. If neither of those things are true, then look, does the patient have diabetes or CKD, or is the patient at increased short-term risk of cardiovascular disease based on a 10-year prevent cardiovascular risk estimate of 7.5% or higher? If so, you can also go ahead and initiate antihypertensive medications to lower and reduce cardiovascular disease risk if average systolic blood pressure is 130 or higher, or diastolic is 80 or higher, for primary prevention of cardiovascular disease. Again, a class 1 recommendation. If all of the above are not true, and you have a pre-hypertensive population that does not have clinical CVD and does not have risk factors for CVD, then initiate antihypertensive medications to lower blood pressure if the average systolic blood pressure is 130 or more systolic, or 80 or more systolic, diastolic, after 3 to 6 months of lifestyle intervention. They also make a note about choice of initial monotherapy versus initial combination drug therapy. This recommendation stays the same as in 2017. In adults with stage 2 hypertension, systolic blood pressure 140 or diastolic blood pressure 190 or higher, initiation of antihypertensive drug therapy with 2 first-line agents of different classes, ideally in a single pill combination, is recommended to improve blood pressure control and adherence. That's a class 1 recommendation. So just slightly different wording, but the same point as in 2017. Also, in adults with stage 1 hypertension, meaning systolic 130 to 139 and diastolic 80 to 89, initiation of antihypertensive drug therapy with a single first-line antihypertensive drug is reasonable, with dose titration and sequential addition of other agents as needed to achieve blood pressure control. Also, class 1 recommendation. Why do they have this recommendation? Because most patients with hypertension require multiple agents for control of their blood pressure. And for those who are candidates for initial combination therapy, i.e. non-frail adults with systolic blood pressure more than 20 and diastolic more than 10 from their target, starting treatment with single pill combination medications rather than the equivalent free pill combinations improves adherence. Moreover, adults with hypertension on single pill combinations have fewer cardiovascular events and all-cause death than those on equivalent multiple pill combinations in observational studies. The evidence that favors this approach comes mostly from studies of greater blood pressure lowering with single pill agents than with single agents with higher adherence rates. There are several smaller RCTs that demonstrated that low-dose combinations of 3 or 4 drugs together reduces blood pressure more effectively than monotherapy over 3 to 6 months of treatment. However, none of those trials of triple and quadruple medications in one pill have evaluated cardiovascular disease prevention. So that's why it's not explicitly included in this recommendation. In general, initial combination therapy with 2 drugs is reasonable in adults with stage 2 hypertension and those at high cardiovascular disease risk. Although most patients with stage 2 hypertension require at least 2 classes of antihypertensive agents, the stepped care approach defined by the initiation of antihypertensive drug therapy with a single agent followed by sequential titration of the dose and addition of other agents as needed is a reasonable treatment for initial pharmacotherapy for stage 1 hypertension. This approach remains a reasonable option in older adults and in individuals who have a history of hypotension or multiple drug-associated side effects. These are the commercially available antihypertensive medications single pill combinations in Table 14. Now we have a revised recommendation in the section on diabetes. In 2017, they had written, in adults with diabetes and hypertension, ACE or ARB may be considered in the presence of albuminuria. In 2025, they say in adults with diabetes and hypertension, ACE or ARB are recommended in the presence of CKD as identified by eGFR less than 60 or albuminuria of 30 or more, and should be considered when mild albuminuria less than 30 is present to delay the progression of diabetic kidney disease. ACE and ARBs have greater efficacy in reducing urinary albumin excretion among the drug classes. That's why they make this recommendation. There's also a revised recommendation in the section on hypertension treatment in patients with chronic kidney disease. They now say for adults with hypertension and CKD identified by eGFR less than 60 with albuminuria of 30 or more, RAS inhibitor either with ACE inhibitor, ARB or both, but not both, is recommended to decrease cardiovascular disease and delay progression of disease. So this is pretty much the same thing. It's just consolidating these two prior statements and upgrading it to a Class 1 recommendation in 2025 when it was previously a Class 2A recommendation. They also note that ACE or ARBs can reduce intraglomerular pressure, which may cause a transient decrease or dip in eGFR up to 30%. This short-term decline in eGFR is not associated with decreased long-term outcomes and should not prompt discontinuation of the ACE or ARB. Now moving on to brains and blood pressure. There's a new recommendation in the section on acute intracerebral hemorrhage. For adult patients with acute spontaneous intracerebral hemorrhage who present with systolic blood pressure between 150 and 220 millimeters of mercury, it can be beneficial to immediately lower the systolic blood pressure to 130 to less than 140 millimeters of mercury for at least 7 days after the ICH to improve functional outcomes, but stop antihypertensive medications if the systolic drops less than 130. That's a Class 2A recommendation in 2025 with no equivalent recommendation in 2017. Why did they add this? Because the INTERACT-2 trial, which was the second intensive blood pressure reduction in acute cerebral hemorrhage trial, showed improvement in secondary outcomes of overall function and quality of life with lowering the systolic blood pressure to less than 140 and maintaining it for 7 days with non-comatose spontaneous ICH patients who presented with a systolic blood pressure of 150 to 220 within 6 hours of onset of ICH. INTERACT-3, which is the third intensive care bundle with blood pressure reduction in acute cerebral hemorrhage trial, concluded that early intensive systolic blood pressure lowering of less than 140, bundled with strict blood glucose control, antipyrexia treatment, and rapid reversal of warfarin treatment within 1 hour, and maintenance for 7 days, was associated with overall improved long-term functional outcome compared with usual care. Both trials protocolized stopping antihypertensive medications if systolic blood pressure dropped below 130. A meta-analysis of INTERACT-2 and ATAC-2, which was the antihypertensive treatment of acute cerebral hemorrhage 2 trial, showed an improved 90-day global disability with incrementally lower achieved systolic blood pressure down to 130. So that's why we have this new recommendation this year. They have a revised recommendation about acute intracerebral hemorrhage. Previously, it was said that in adults with ICH who present with systolic blood pressure more than 220, it is reasonable to use continuous intravenous drug infusion and close blood pressure monitoring to lower systolic blood pressure. In 2025, they say in adults with acute spontaneous ICH requiring acute blood pressure lowering, careful titration to ensure smooth, non-labile, and sustained control of blood pressure, avoiding peaks and large variability in systolic blood pressure can be beneficial for improving functional outcomes. Why? Because a post hoc analysis of INTERACT-2, the trial we mentioned in the last slide, found that increased standard deviation of systolic blood pressure during the first 24 hours had a linear association with death and severe disability in 90 days. A meta-analysis of INTERACT-2 and ATAC-2 also showed a continuous association between achieved systolic blood pressure and lesser variability during the first 24 hours after ICH and the distribution of modified ranking scale scores at 90 days, which suggested that avoiding large fluctuations in blood pressure is beneficial. In the acute ischemic stroke section, there is a revised wording for the recommendation. In patients undergoing successful brain reperfusion with endovascular treatment for a large vessel occlusion, lowering systolic blood pressure less than 140 millimeters of mercury within the first 24 to 72 hours after reperfusion can worsen long-term functional outcome. That's a Class 3 recommendation due to harm in 2025. Why did they say this? Because randomized controlled trials and meta-analyses of trials evaluating blood pressure lowering after successful endovascular thrombectomy to date have shown either harm or no benefit. The ENCHANTED-2 MT study, which was enhanced control of hypertension and thrombectomy stroke study, comparing post-endovascular thrombectomy systolic blood pressure goals of less than 120 and 140 to 180, was stopped early due to an increased rate of worse global disability in the less than 120 group, with an odds ratio of 1.53, so pretty significant. Optimal BP, which compared post-endovascular thrombectomy systolic blood pressure goals of less than 140 versus 140 to 180, was also stopped early due to lower rates of improved outcomes in 90 days, namely a modified Rankin scale score of 0 to 2 in 39% of the less than 140 group versus 54% in the 140 to 180 group. That's why they have this recommendation. They also make a note about mild cognitive impairment and dementia. In adults with hypertension, a goal of less than 130 is recommended to prevent mild cognitive impairment and dementia. This is upgraded to a Class 1 recommendation in 2025 compared to 2A in 2017. Why? Because meta-analyses of randomized controlled trials have strongly supported a beneficial effect of blood pressure reduction on dementia risk. New results from the SPRINT Mind Legacy follow-up show that, unlike mortality, significant benefit in reducing the risk of incident mild cognitive impairment alone, with or without dementia, continued for at least 7 years. A non-statistically significant reduction in dementia risk remained, with each of these findings a result of only 3.5 years of intensive blood pressure treatment. That's why they have this recommendation and upgrade from 2A to 1. Moving on to the section in hypertension and pregnancy, there are a number of recommendations that previously existed in the ACOG guidelines but come in for the first time in the AHA and ACC guidelines. Pregnant individuals with systolic blood pressure of 160 or diastolic blood pressure of 110 or more, confirmed on repeat measurement within 15 minutes, should receive antihypertensive medication to lower blood pressure to less than 160 and less than 110 systolic and diastolic within 30 to 60 minutes to prevent adverse events. Severe hypertension in pregnancy, which is the new term for hypertensive urgency in pregnancy, is defined as systolic blood pressure of 160 or more or diastolic of 110 or more. When left untreated, it can result in maternal stroke, renal insufficiency or kidney failure, MI, heart failure, placental abruption, preterm birth, fetal growth restriction, and maternal death from intracerebral hemorrhage and or stillbirth or perinatal death. Immediate release oral nifedipine has been shown in a meta-analysis to be associated with faster time to achieve target blood pressure, specifically in pregnancy, although it is not generally recommended for the acute treatment of other types of hypertension. The 3 drugs used for urgent blood pressure control in pregnancy are labetalol, hydralazine, and nifedipine. Labetalol has an onset of action of 1 to 2 minutes, hydralazine 10 to 20 minutes, and nifedipine immediate release 5 to 10 minutes. Next, pregnant individuals with chronic hypertension defined as pre-pregnancy hypertension or systolic blood pressure 140 to 159 and or diastolic 90 to 109 prior to 20 weeks of gestation should receive antihypertensive therapy to achieve blood pressure less than 140 over 90 to prevent maternal and perinatal morbidity and mortality. There was a Cochrane review and meta-analysis of 58 trials evaluating the treatment of non-severe range hypertension in pregnancy, defined as systolic less than 160 and diastolic less than 110, and the Cochrane review concluded that the use of antihypertensive medications reduced the risk of severe range hypertension with a risk ratio of 0.49, but did not significantly reduce the risk of preeclampsia. However, the TRAP trial, which is the chronic hypertension and pregnancy trial, which randomized 2,400 women with chronic hypertension to receive antihypertensive medications to reach target blood pressure less than 140 compared with no treatment, unless systolic blood pressure was greater than 160 or diastolic more than 105, demonstrated an 18% absolute risk reduction in a primary composite outcome of preeclampsia with severe features, preterm birth, placental abruption, or fetal neonatal death without evidence of increased risk of fetal growth restriction. That's why they have this recommendation. There is one more new Class 1 recommendation in the section on hypertension and pregnancy. Individuals with hypertension who are planning a pregnancy or who become pregnant should be counseled about the benefits of low-dose aspirin to reduce the risk of preeclampsia and its sequelae. Why? In a meta-analysis, daily low-dose aspirin taken during pregnancy after 12 weeks gestation has been shown to significantly reduce the risk for preeclampsia in individuals at moderate or high risk compared with placebo, with a pooled relative risk of 0.85. Aspirin use was associated with significantly reduced risk for preterm birth, small for gestational age or intrauterine growth restriction, and perinatal mortality in pregnant persons at increased risk for preeclampsia without increasing the risk for postpartum hemorrhage. Only individuals with no prior adverse events or allergy to aspirin should be advised to take low-dose aspirin for preeclampsia prevention. I think this is particularly interesting because this is one area where aspirin is still indicated for prevention. Now, finishing up the section on hypertension and pregnancy. Individuals with hypertension who are planning a pregnancy or who become pregnant should not be treated with atenolol, ACE inhibitor, ARB, direct renin inhibitors, nitroprusside, or MRA to avoid fetal harm. Therapeutic classes are not universally recommended or avoided because potential toxicity actually differs among agents within classes. Atenolol in particular has been associated with growth restriction and lower fetal weight and should be avoided in pregnancy. But this is likely not a class effect because other beta-1 selective agents such as metoprolol have not demonstrated similar associations with growth restriction, and labetalol is a preferred agent with the most reassuring fetal safety data. ACE, ARBs, and direct renin inhibitors are fetotoxic in the second and third trimesters of pregnancy due to their effects on the developing renal system, leading to oligohydramnios and AKI. So that's a long-known fact. Adverse effects in the first trimester may be secondary to hypertension or medications. Based on the mechanism of action and data from animal studies, fetal exposure to spironolactone may cause feminization of a male fetus or growth restriction and is generally not recommended, even for individuals with primary aldosteronism in the mother. The feminizing effects appear to be dose-dependent from spironolactone. There are few human data on the nitroprusside safety in pregnancy, but data from animal studies show that nitroprusside crosses the placenta and may lead to fetal cyanide toxicity. Now we can move on to another interesting section about resistant hypertension. Resistant hypertension is defined as blood pressure above goal despite treatment with 3 antihypertensive medications with complementary mechanisms of action, including a diuretic at maximally tolerated dose, or blood pressure at goal but requiring at least 4 antihypertensive medications. In adults with resistant hypertension, a more detailed evaluation of secondary causes to include careful review of all medications and removal of those with interfering effects on blood pressure is beneficial for lowering blood pressure and simplifying treatment. That's a Class 1 recommendation. Nothing groundbreaking, it just happened to not be included in the 2017 recommendations. They note that approximately 20% of adults with hypertension report regular use of over-the-counter or non-prescription medications that may directly raise blood pressure or interfere with antihypertensive drug efficacy, such as NSAIDs or nasal decongestants. These medications are associated with uncontrolled blood pressure and should be reviewed during the evaluation of patients with resistant hypertension. For example, any antihypertensive medication can interact with NSAIDs, sympathomimetics such as pseudoephedrine or dextroamphetamine, or venlafaxine, and cause reduced ability to lower blood pressure. They now introduce the idea of renal denervation in 2025, or I guess reintroduce, as it is making a comeback. All patients with hypertension who are being considered for renal denervation should be evaluated by a multidisciplinary team with expertise in resistant hypertension and renal denervation. That's a Class 1 recommendation with no equivalent in 2017. For patients with hypertension for whom renal denervation is contemplated, the benefits of lowering blood pressure and potential procedural risks compared with continuing medical therapy should be discussed as part of a shared decision-making process to ensure patients choose the therapy that meets their expectations. That's a Class 1 recommendation in 2025 with no equivalent in 2017. Predictors of blood pressure response to renal denervation have not been consistently demonstrated among clinical trials. Only 60 to 70% of patients undergoing renal denervation experience a meaningful reduction in ambulatory systolic blood pressure of at least 5 millimeters of mercury in clinical trials. Renal denervation is currently performed strictly via the femoral artery approach, with the immediate risk associated with an RDN procedure not significantly greater than a risk associated with femoral access alone. Due to the risk of renal artery stenosis after the procedure, patients will require ongoing surveillance imaging. The contraindications to renal denervation include neurogenic orthostatic hypotension, pregnancy, fibromuscular dysplasia, a stented renal artery aneurysm, significant renal artery stenosis, or known kidney or secreting adrenal tumors. Finally, the last section with changes is the section on hypertensive emergencies and severe hypertension for non-pregnant and non-stroke patients. Notably, they have replaced the term hypertensive urgency with the term severe hypertension, but the term hypertensive emergency still stands. For adults with severe hypertension with blood pressure exceeding 180 over 120, who are hospitalized for non-cardiac conditions without evidence of acute target organ damage, intermittent use of additional intravenous or oral antihypertensive medications are not recommended to acutely reduce blood pressure, Class 3 harm. This is important because this is something that unfortunately happens all the time in inpatient care. Antihypertensive drug treatment should be used with extreme caution in hospitalized patients with asymptomatic severe hypertension because spontaneous falls in blood pressure without any antihypertensive agents occur commonly at a rate of 40 to 50%. Observational studies have shown that initiation or intermittent use of additional IV or oral antihypertensive medications in patients hospitalized for non-cardiac conditions are associated with increased risk of in-hospital mortality, acute kidney injury, and prolonged hospital stay. Asymptomatic patients with severe hypertension can be treated with careful and frequent monitoring using standing medications and avoiding as-needed medications. Now that we have systematically gone through all of the specific recommendation changes between the 2017 and 2025 guidelines, I will go through the top 10 take-home messages that were selected by the AHA-ACC guideline writers. 1. High blood pressure is the most prevalent and modifiable risk factor for the development of cardiovascular diseases, including coronary artery disease, heart failure, atrial fibrillation, stroke, dementia, chronic kidney disease, and all-cause mortality. The overarching blood pressure treatment goal is less than 130 over 80 for all adults, with additional considerations for those who require institutional care, have a limited predicted lifespan, or are pregnant. 2. Clinicians should collaborate with community leaders, health systems and practices to implement screening of all adults in their communities and implement guideline-based recommendations regarding prevention and management of high blood pressure to improve rates of blood pressure control. 3. Multidisciplinary team-based care is effective in assessing and addressing patient access to medications and other structural barriers to support individual patient needs and thereby reduce barriers to achieving hypertension control. Team members may include physicians, pharmacists, nurse practitioners, nurses, physician assistants or associates, dietitians, community health workers, and other healthcare professionals. 4. Blood pressure is classified by the following framework. Normal blood pressure is defined as less than 120 systolic and less than 80 diastolic. Elevated blood pressure as 120 to 129 systolic and less than 80 diastolic. Stage 1 hypertension as 130 to 139 systolic or 80 to 89 diastolic. And stage 2 hypertension as 140 or more systolic and 90 or more diastolic. 5. For all adults, lifestyle changes including maintaining or achieving a healthy weight, following a heart-healthy eating pattern such as DASH, reducing sodium intake, increasing dietary potassium intake, adopting a moderate physical activity program, managing stress, and reducing or eliminating alcohol intake are strongly recommended to prevent or treat elevated blood pressure and hypertension. 6. Initiation of medication therapy to lower blood pressure in addition to lifestyle interventions is recommended for all adults with average blood pressure of 140/90 or more and or for selected adults with average blood pressure of 130/80 or more who have either clinical cardiovascular disease, previous stroke, diabetes, chronic kidney disease, or increased 10-year predictive cardiovascular risk estimate of at least 7.5% as defined by the PREVENT equations. 7. In adults with average blood pressure of 130/80 or more and at lower 10-year cardiovascular disease risk defined by PREVENT risk equation estimate of less than 7.5%, initiation of medication therapy to lower blood pressure is recommended if average blood pressure remains 130/80 or more after an initial 3 to 6 month trial of lifestyle modification. For all adults with stage 2 hypertension, the initiation of antihypertensive drug therapy with 2 first-line agents of different classes in a single pill fixed-dose combination is preferred over 2 separate pills to improve adherence and reduce time to achieve blood pressure control. 9. Home blood pressure monitoring combined with frequent interactions with multidisciplinary team members using standardized measurement and treatment protocols is an important integrated tool to improve rates of blood pressure control. Reliance on cuffless devices, including smartwatches, for accurate blood pressure measurement should be avoided until these devices demonstrate greater precision and reliability. 10. Severe hypertension in non-pregnant individuals defined as blood pressure of more than 180/120 without evidence of acute target organ damage should be evaluated and treated in the outpatient setting with initiation, reinstitution, or intensification of oral antihypertensive medications in a timely manner. Okay, we have covered a lot today. We have done a very systematic comparison of the 2017 recommendations and the 2025 recommendations and identified the specific wording changes between these 2 guidelines. I hope you found this granular comparison insightful. I encourage anyone who has time to check out the full guideline to look at the ACC and AHA guideline hubs, including the guideline at a glance, as well as the commentaries, including from my colleague, Dr. Steve Jurashek. Thank you very much for joining me on a deep dive of this guideline. Until next time.